Thank you. Good afternoon and welcome to West Berkshire Health Scrutiny Committee. I'm Councillor Claire Rolls, Chairman of the committee. Today I'm supported by Councillor Alan Macro as Vice Chairman. Other members of the committee in the meeting this afternoon are Councillors Tony Linden and Councillor Andy Moore. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Service Director, Adult Social Care. We also have joining later Belinda Seston, who's Interim ICB Director of Berkshire West, Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. Sarah Deason from the Advocacy People, and I can see Sarah's joined on Zoom. Welcome, Sarah. Mark Ainsworth, who is Director of Operations, South Central Ambulance NHS Service NHS Foundation Trust. Welcome to Mark as well. I can see you've joined on Zoom. And we're also going to be joined by Bernadine Blees, who's Divisional Director of Adult Community Health Services, Berkshire Healthcare NHS Foundation Trust, who will be joining us later in the meeting. Vicky Phoenix is the clerk for the meeting, and the meeting is also being live streamed via YouTube, and Tom Dunn is the Zoom host. Before we start proceedings, I'd like to explain for the benefit of members of the public who may be watching that today's meeting is being held both over Zoom and with councillors present in the meeting room. The meeting is being live streamed on YouTube, so members of the public are able to also follow proceedings. During the meeting, I would ask that anyone wishing to speak to raise their Zoom hand, please, and all voting will be done by a show of actual hands. If we hear the evacuation alarm today, we must leave the building immediately via the emergency exit. The assembly point is the Dolphin car park, and if the lockdown alarm sounds, we will remain seated and await instructions from officers. We will adjourn the meeting until such time as it's safe to proceed. Does anyone have any questions before we begin the meeting? Good. First of all, may I have any apologies, Vicky, for absence?
Yes, we've received apologies from Councillors Graham Bridgman and Councillor Jeff Beck. We also have apologies from Andrew Sharp from Health Watch, and we have Sarah Deason for Advocacy People in his place. Thank you.
Moving on to agenda item number 2, which is the minutes of previous meetings. We have 2 sets of minutes this afternoon, members. The first one for the meeting held on the 23rd of May, and the second is for the meeting held on the 14th of June this year. So has everybody had a chance to firstly read the minutes, and do I have any comments? Yes, Councillor Linden.
No, Chairman.
Oh, sorry. Turn your mic on. Thank you.
No, Chairman, I would just like to propose both minutes, Chairman.
Do I have any comments or amendments from members before I take that?
No, I'm happy to second the first set of minutes.
Okay.
I can't second the second.
Because you weren't there.
Because I wasn't there.
Right, so we have Councillor Linden proposing the minutes of the 23rd of May, and we have a seconder for that as well. So could we have a vote on those? Great, I think that's carried. And do I have a proposal for the second set of minutes? Councillor Linden, do I have a seconder? Thank you, Councillor Macro, and we have a vote on that.
Stay.
Okay, and we've got an abstention, obviously, where we have one member absent. Great, well, I will sign those minutes. Thank you. So moving on to agenda item number 3, which is declarations of interest. Do I have any declarations of interest, members, this afternoon? No? Great, thank you. Moving on to agenda item number 4, petitions. Vicky, do we have any petitions this afternoon?
We have not been notified of any in advance of the meeting.
Okay, great, thank you. Well, now, members, we move on to the substantive piece of the meeting, which is agenda item number 5, the South Central Ambulance Service NHS Foundation Trust. And I'd like to welcome Mark Ainsworth. Mark, thank you very much for joining us this afternoon. We note that, just to set the scenes for members, that representatives from the ambulance service have been asked to present an overview of performance, current demand levels, waiting times, key issues, and winter service plans for 2022 to 23. And we have a full report in the pack, which was circulated in advance of the meeting and available for the public. So may I hand over to Mark to present the highlights of the report, and then I'll invite questions from members. Mark, the floor is yours.
Thank you, and apologise, slight technical difficulties joining by Zoom because our IT policies block Zoom, so I've had to quickly grab a different PC, so apologies for that. Will somebody be showing the slides your end on the performance?
Yes, we'll be screen sharing, so if we can do that now, Vicky, and then you can take us through them. Thank you.
Thank you, Vicky. So what I've done here is try and take you through our current 999 performances, and I'll show you the Berkshire West area compared to the SCAS performance as well. So the first slide will show you our current performance from April through to August. Just wait for Vicky to...
Yeah, we're just sorting the slide.
Okay.
Here we go. Thank you, Vicky.
So you can see here, if I talk you through the numbers on the right-hand table, the top one is showing you the number of incidents. So if I look at April, 3,246 category 1 calls, 23,000 category 2 calls, and below there, the table below is the performance associated with those. What we have seen as we've come out of the pandemic, and fingers crossed we continue to come out of it, has been an increase in our category 2 calls. So they are our emergency calls that require an 18-minute response. And we are seeing patients who would normally present as a category 3, which requires a 2-hour response, becoming category 2 calls. So that's indicating there is a higher acuity of patients calling 999 from our communities. You can see there we are actually failing to achieve all of our performance standards in category 1 through to category 4. However, when we look at the national picture, SCAS still does benchmark very well. We are 7th out of 10 trusts for our category 1, but we're in the top quartile. We're normally 1st or 2nd for the category 2, 3, and 4. So our current focus is improving our category 1 performance, those life-threatening calls where our average response time should be 7 minutes. The next slide will show you where Berkshire West performance is in comparison to that. And you'll notice that the category 1 performance time has increased by about 40 seconds to the SCAS average. So we are seeing some more challenges across the Berkshire West region with some of the rural areas in getting to those life-threatening calls that a little bit quicker. The next slide is looking at where our patients end up. So how many do we take the 999 call? A percentage of those patients will be dealt with by clinicians in our control rooms through what is called hear and treat. We will send an ambulance or a rapid response car to the remaining calls. Some of those patients will be dealt with on scene by our clinicians. That's known as see and treat. And our remaining patients are see, treat, and convey. And we have a number of options when we convey patients to hospital. They don't all go to the emergency department. And you can see from the bottom right-hand table there, you've got see, treat, and convey to ED only, and see, treat, and convey to non-ED. So we take anywhere between 4 and 7% of our patients to other locations away from the ED. That could be a coronary care unit, it could be a minor injuries unit, or other speciality. So looking at our current performance for SCAS, our hear and treat for this year is 12.27%. That's looking at the bottom left table. And you can see year on year, we've seen a gradual growth in that hear and treat. The slight drop from last year is because we had a very high hear and treat during the second year of the pandemic. So there was obviously a lot of worried well patients that were calling us, and we're able to treat them over the phone by giving them advice or even pointing them to the COVID specialist services that we had available. Our see and treat performance is at 34%, and then the remainder is our conveyance to hospital, which that be split by ED or non-ED. There is an urgent and emergency care target set by NHS England for this year of 49% of patients being conveyed to ED. So that should be a maximum of 49%. So we are 0.1 over that, 0.01 of that at the minute. And we have a very active campaign looking at introducing additional care pathways that we can take patients through to avoid them going to ED. So we're working with urgent care response teams, other community partners to increase the number of pathways available in the community for our paramedics to access, but then also looking at hospitals and working with all of our acute trusts in trying to get patients into more non-ED locations. The next slide will show you how Berkshire West compares to that. And you can see there that our hear and treat is at 10.4% for Berkshire West. Our see and treats are 37.9%, and our conveyance is at 51.7%. So appreciate we can't keep flicking backwards and forwards, but I can see it on another screen. So the see, treat and convey for SCAS is 53%, whereas for Berkshire West it's only 51.7%. So we are treating more patients through see and treat in the Berkshire West area because of the pathways that we've got available to the paramedics, rather than taking them into the hospital environment. Next slide, please. One of the other areas that is a real focus for us is how long it takes us to turn our ambulances around at hospital. So the national target is that the patient should be handed over within 15 minutes of arrival of the ambulance outside the emergency department. This has been a real challenge during COVID, with hospitals having a high bed occupancy. We have seen our ambulance handover delays increase, and there's obviously been a lot of national and local media focus on the number of ambulances being held outside certain hospitals. Our main focus for our region across the 4 counties we cover has been the QA hospital down in Portsmouth, where we will often have 20 ambulances waiting to offload patients at peak periods. So what this table here is showing, the bar chart is showing the average turnaround time, and this is for all hospitals across our SCAS region. And the dot in each month is the number of patients who have arrived at all the acute trusts that we have conveyed. And you can see that we did see a slight increase in July with our average handover time. And this varies between 40 and 43 minutes. So 15-minute target, we're at 40 to 43 minutes. The impact of that is it's taking ambulances out of the system to respond to further patients awaiting a response. So we are working closely with all of our acute trusts to try and reduce the handover time that they take to take our patients. If you go on to the next slide, you will see the picture for Berkshire West. So obviously predominantly patients from Berkshire West going to Royal Berks. We do have a very good working relationship with them at Royal Berks. When we do experience an increase in delays, our commanders and managers can speak to the hospital on-call teams very quickly, and we tend to get things resolved very quickly. We have seen some challenging weeks where the hospital bed occupancy is high, but we have, like I say, got a good process to try and resolve those as quickly as we possibly can. The next slide is our community engagement team. So these are our community first responders who volunteer to respond on our behalf, and they attend a range of calls, including Category 1 life-threatening calls, but they will also attend patients who have fallen and are non-injured, and also patients who have pulled their alarm cord where we've got concern for welfare. This also includes, in some areas of SCAS, our military co-responders. So again, these are military personnel who we've trained, who we provide a car to, or they get a sponsored car and they respond on our behalf. And also in Hampshire, it includes our fire co-responders, where the fire service provide a number of resources that respond on our behalf. So what the tables are showing you is the number of calls that these volunteers attend for SCAS. And we're focused predominantly on the category 1 calls, because firstly, this is where they can have maximum impact on the patient by getting a defibrillator and CPR to them as quickly as possible. So in the top chart, it's SCAS, and you can see there across SCAS, 7.3% of patients presented with a category 1 call had one of our volunteers there first. The bottom table is showing the Berkshire West picture, which is slightly lower at 1.3%. The performance, so if you look at the line that says Cat 1 means stopped by the community engagement team, this is the performance measure that we allocate to them. So there was the performance for our category 1 for SCAS in August was 9 minutes 44. And when we add in our community engagement performance for the Berkshire West, it reduced it to 6 minutes and 5 seconds. So whilst we are seeing a lower number of incidents attended by our community engagement team, the effect they have when they get there is much greater, because they're in the community, rural communities, where they can respond to patients that much quicker. So that's the opening slide deck around our performance. I'm happy to take any questions on there first before we go on to the other areas, which I think you wanted me to cover, our CQC and also preparedness for winter.
Thank you, Mark. Members, do you have any questions on that first stage of the presentation? Yes, Councillor Moore. Sorry, I have got some hands up. So, Councillor Moore, do you want to go?
Yes, but I don't seem to be able to get my... That's better. Yes, a couple of questions for you. Thank you for the presentation. I was just interested, I mean, you've given us a number of stats on the hospital delays. I mean, is there anything practical that the ambulance service can do about those, or is it you're just really in their hands?
So the main focus for us is to reduce the number of patients we take to ED. So as I mentioned earlier, the community pathways are treating as many patients at home just to ease that pressure on the front door of the emergency department. Within the CQC report, which I'm sure you would have had the chance to read, is a very lengthy document, but within there, the CQC also highlight they feel there's more that SCAS can be doing to bypass the hospitals that are busy. So we're currently working with NHS England and the Acute Trust to look at what we can do differently. If a hospital is queuing, and I'll talk about Hampshire because that's where our main concern is. So if the QA hospital is queuing, we are still commissioned to take patients to the closest hospital. And if we wish to divert away from that hospital, we have to request that divert through the hospital system. So the QA hospital would have to speak to Southampton and Winchester to see if they'll take their patients. The challenge we have with Royal Berks, if we're queuing outside of Royal Berks, the next hospital is some distance away. So we'd be going to Basingstoke, Wexham, or even to Oxford. But the CQC view is that we can do more to try and influence those diverts of patients. And that is one of the areas that we're focused on as one of our actions within our CQC recovery plan. But the key thing for us will be avoiding ED wherever we can.
Sure, which leads to my second question. I mean, the stats for Berkshire West, if I've got this right, the alternatives to going to ED seem to be rather fewer than I think your SCAS overall. Did I pick that up right? I'm looking at slide...
Between 4 and 5.
Yeah, probably.
Slide 4 and slide 5.
I don't have numbers on where I are.
Okay. So if I'm looking for this current year, our non-ED conveyance across SCAS is 4%, whereas in Berkshire West it's 3.5. So there's sorry, 3.9. So we're 0.01 difference between SCAS, the rest of SCAS and Berkshire West.
But I got a little confused because the ED figure for Berkshire West averaged 96%, but the ED figure for SCAS averaged 49%.
Apologies for that. It's the way, yeah, it's the way that those slides are presented. So that's a mistake my end. I should have checked the numbers. But if you look at the way that's presented on the Berkshire West, that's to show where 100% of the conveyances went. So of the 51.7% that we see, treat and conveyed, 96% of those went to ED and 3.9 went to non-ED.
Right.
And yes, I agree. My mistake. We should have shown both comparators the same.
So 3.9% is actually probably about is about 2%, isn't it? By comparison with about 4% in the previous. I just wondered whether there was any explanation of why Berkshire West didn't appear to have so many options outside ED.
So it has. Berkshire West has got a good number of options. So if we're looking at the non-ED, it's less than 1% difference between the rest of SCAS. So we are accessing the community response, the urgent care response teams. They'll provide a 2-hour response service, some are category 3 and 4 calls. We're accessing district nurses, we're accessing GPs. The GP services that employ paramedics, we can access them to come out, because obviously they have greater understanding of the patient's conditions. So yeah, we're not concerned around the number of community pathways compared to the rest of our area.
Okay, thank you.
Thank you. Councillor Macro.
Thank you. I'd like to go back to the issue of the busy hospitals with queues of ambulances outside, because there's various things about that. First of all, you've got an ambulance tied up, and that's going to affect your response times. You've got a patient lying in the back of an ambulance rather than being treated in hospital, which is not good for them. And I think we've had a suggestion that it'd be getting much worse outcomes for some patients. So, in West Berkshire, although we do have a choice of hospitals, so just to, if you're in, say, Newbury, to go to North Hampshire is not that much further than the Royal Berks, and it's probably quicker, in fact. So I just would like to know what you can do, what you are doing to try and address that, try and get those turnarounds down.
So Royal Berks turnaround time is better than Basingstoke. So we are quicker for most patients to go to Royal Berks than we are to go down to Basingstoke. But we do regularly, throughout the day, we monitor the number of patients going into each hospital. And as we start to see any delays starting to build, we have an immediate call with their site manager to look at what actions they can take to reduce those delays. And if we start to see a number of houses queuing, we would then start putting messages out to our crews to consider other hospitals. So this is not a formal divert, but if a patient is on the border, so if they are down, let's say Tadley or Aldermaston area, we know that we're sort of halfway between the two hospitals. And if it is busier at Royal Berks, the crews would make that decision dynamically to say, well, okay, we know we're going to be quicker at Basingstoke. Let's go down to Basingstoke and come back. The other thing to take into consideration is where the patients have ongoing treatment. So again, picking on that geography, most of those patients may have outpatients or ongoing long-term care through Hampshire hospitals at their Basingstoke site. And it makes sense if they present to us with the same condition, we take them to that hospital to know them where all their patient care records are. So there's a number of decisions that the clinicians out in the ambulances will make around which hospital they're going to go to.
Thank you.
Does that satisfy you? Yes.
Well, it does sound very sensible that the crews can actually make a normal spot decision rather than having to go through some procedure. Thank you.
Thank you. Mark, I just have one question. When you were talking about the hospital delays, you mentioned about obviously seeing that impact during COVID. Are you seeing a marked difference now that we're sort of moved out of COVID a little bit more, or is it still very much as the delays are being caused by COVID still being with us?
I don't think COVID is the issue now. If you look at the bed occupancy levels for COVID, it is much lower than what we've seen over the last 2 years. But obviously the acute trust is starting to catch up with all the patients with long-term conditions and that require elective surgery. So the main measure that impacts on handover delays is the actual total bed occupancy level. So as a hospital gets close to sort of 90% plus bed occupancy, there's a direct correlation then between the number of ambulance handover delays. Just to give you some numbers, for the month of August this year, we lost 317 hours at the Royal Berkshire Hospital, which is much lower than a number of other acute trusts. And just looking at the Queen Alexandra Hospital in Portsmouth, we lost 2,721 hours. So just putting in some perspective, whilst we're concerned around all our delays, we are very focused on those hospitals that have the bigger impact on us.
Thank you. Okay, are you happy to move on in the next?
Yes.
Thank you. Do we need to share slides, or are you? No, we're not sharing slides.
No, so again, I don't know if members have had the chance to read our CQC report, but we welcomed the CQC in to carry out their inspection. We have previously been rated as good. They came in to do an inspection on our well-led domain, and they found a number of issues within our organisation, which they have highlighted in their report. We have listened, we have fed back to the CQC, we have accepted the report, and we are taking some rapid actions to improve and turn around that report rating as quickly as we possibly can. We've split our work streams into 4 main areas to improve the CQC rating. The first one is patient safety and experience. So the CQC highlighted some issues with our safeguarding reporting. So whilst the operational crews are reporting correctly, there were some process errors with us then passing those safeguarding referrals on. They highlighted some challenges with our patient safety incident management. So that is where we declare serious untoward incidents or significant incidents where there could have been patient harm. So although we had a robust process agreed with our local partners, it wasn't compliant with CQC standards. We have rectified that already, and we are now compliant with that area. They highlighted that some of our medical devices and our processes around medical devices were not robust enough. So we're reviewing how we report and store and maintain all of our medical devices. They also highlighted some infection prevention and control issues. This was predominantly around pigeons that got into some of our workshops and garages. And obviously some of the equipment then, and including the ambulances, they were found to be had pigeon droppings on them. So again, we have carried out a process to try and get those birds out of our garages, but they are keen to come back in, let's say. So that is an ongoing process just to make sure we can keep our feathered friends away. Our next work stream is looking at culture and well-being. So as part of the CQC inspection, they did a staff survey, and they had about 18% of our staff respond to them. And they highlighted that whilst they felt their direct line managers were very supportive, they didn't feel that some of the things they were raising higher up within the organisation were being listened to and actioned. So again, we've got an active work stream looking at our leadership, looking at how we train our leaders, looking at any issues around sexual harassment in the workplace, and also making sure we are listening to staff. Now, that is something we're not going to turn around overnight. It's going to be a long campaign to try and build trust with the staff. They feel they can speak up, they will be listened to, but more importantly, they will get a response. I think that's where it's a breakdown. Is staff hadn't had a response to some of the issues they'd raised. The third area is around governance and being well led. And one of the things CQC identified, they felt there was a disconnect between the executive and non-executive board and the rest of the trust. So they didn't feel the executive team were fully sighted on the issues. So that came throughout reviewing board papers and listening to the executive team and also the other leaders, the rest of the leadership team. The staff also reported back that the executive team weren't visible. And if you think we cover 4,000 square miles and we have 7 execs, so it's difficult for them to go out and be visible to all staff. But we've already started a campaign where our exec team are being out and being more visible amongst the workforce. One of the actions we took during COVID was that we stopped our exec team going out into operational stations, so it didn't take a risk of them bringing COVID into the workplace or also then picking up COVID. So I think there was a bit of a disconnect between what the CQC heard and the reason why we'd made those decisions. The next area is our performance recovery. So as I highlighted at the start, we're not delivering our performance standards, although we do benchmark very well. So we've got a number of actions there looking at how we can improve our response to patients. Are we using all of our resources as effectively as we can? Reviewing our recruitment and retention actions to make sure that we don't see staff leaving to go to other organisations, but also how can we attract more people in to work within South Central. We've started that by employing some Australian paramedics. We've got 41 Australian paramedics that are over with us now. We're looking at opportunities within South Africa and Eastern European paramedics to again increase our clinical staffing levels. We don't have a challenge bringing in non-clinical staff, so emergency care assistants, but we do have a challenge with our clinical staff. The other area of staff recruitment focus is around our 999 call handlers. So those staff answering the 999 calls from the public. There is a very high staff turnover within that grade of staff because the pay, it's a national pay scale. And unfortunately, you can earn more at Tesco's or as a delivery driver, you can take in 999 calls. So there's some national work looking at the pay and terms and conditions for our call handlers. But also we're looking at where else we can recruit staff from. So we've got staff on the Isle of Wight now taking 999 calls for South Central region. We're also then looking at the training we provide our staff. So one of the reasons staff leave is because they feel they can get enhanced training from other organisations. So we're seeing a number of paramedics leave to go and join GP practices as first contact practitioners, where the GPs are offering them a much better pay rate, but also offering them training opportunities that aren't afforded to them within the ambulance sector. So that covers the 4 main work streams. The CQC will obviously be monitoring our progress on that. NHS England will be allocating us a turnaround director who will monitor our progress. And we have NHS England representatives attending all of our board and sub-board exec committees to monitor progress along those actions. We've got the next 10 weeks to finalise the plan and deliver the key aspects, and then that will be monitored over the coming, I think the CQC are due back in November to see progress, and then they'll come back and do a re-inspection in the early part of next year. Now, clearly, to move from good to inadequate for well-led has been a really difficult thing to listen to and take in. It is reflective of where we are in the CQC eyes, and the key thing for us as an organisation is turn the organisation around as quickly as we possibly can to get that good rating back in our CQC rating.
Thank you, Mark. I'll open up for questions to members. Councillor Linden.
Thank you, Chairman. Yes, hello, Mark. It's, to be honest with you, I read the report in detail and it really is a damning report. I mean, we've had a few poor reports, but this one is damning. I'm glad that you are taking it seriously and certainly would like to discuss. I know we've got PERDA in April because we've got local election, our all-out elections are in May. But obviously, I think, you know, this committee needs to be aware of what's going on. And, you know, hopefully you can turn most of this around or get the most serious things sorted out, because otherwise, certainly I suspect the government Secretary of State for Health will be intervening far more. It really is bad. And I think, you know, this needs to, in my view, go back to not just the board, but also the non-executive board members as well. You know, the CEO from downwards, to be honest with you, because it is really, really damning. So that's my first point. I'm going to ask some other questions, and I'd like the Chairman, if, with agreement, after Councillor Macro, just to have my other to raise. It's just two different questions. Okay.
Yeah, we'll come back to you, Councillor Linden. Councillor Macro.
Thank you. Just looking at the kind of introduction to the CQC report, a couple of things that stood out, that one of which you've touched on, one I don't think you have. One was safeguarding, and the CQC pointed out that they would advise concerns over this in November 2021. There's a big concern to me that an issue has been raised and they're still concerned about it, you know, 9 months later. The other one is the leaders were dismissive of people raising concerns, and sometimes staff who raised concerns were treated badly. And this seems to be a recurrent theme. I was reading quite a few stories in the newspaper of various trusts around the country being seemingly treating whistleblowers badly. And I'm just wondering what you're doing about that, please.
If I start with the safeguarding one, the inspection in November 21 was an inspection of our 111 service. And they highlighted through there some challenges with the upward reporting of safeguarding referrals. So the clinical team and the patient safety team put some processes in place through 111. Unfortunately, you know, this is a bit of an own goal. We didn't make sure at the time, whilst we'd rectified 111, that we then rectified our patient transport services and 999 services. So as the CQC have come back in, they knew that they'd identified a challenge within the 111 service, and they identified a very similar challenge within the 9s and PTS. So that's why there's the reference back to the November 21 inspection. The actions that sit behind this are very robust, because we know that there could be patients at risk if we don't upwardly report our safeguarding. To reassure you, our staff are reporting appropriately. If anything, the CQC felt we were over-reporting in some areas because some staff were being over-cautious. It was the then onward referrals that were not being managed as effectively as they should have been, with some of them taking too long to onwardly refer. So we have increased the safeguarding team. We are out to advert at the moment for a new head of safeguarding. And I think we've got 4 safeguarding practitioner adverts out to increase that team, to give them the capacity to make sure we do support and manage those patients or those referrals as effectively as we can. We've also brought in some safeguarding expertise from a specialist nursing director who was recommended to us by the CQC. So she is currently in with us, supporting us with that process. With regards to the, does that answer the question on the safeguarding one before I go on to the staff speaking up?
But I think you've reassured me. Thank you.
The staff speaking up, again, 2,000 staff within the sector that was assessed by the CQC across 4,000 miles. It's really difficult for a paramedic to get their voice heard by the chief executive. But we do have ways and means in place already where the staff can make suggestions. They can raise concerns through their local management team, which then should be escalated through to myself or to the executive team if it requires that level of intervention. That system had failed, and we acknowledge that it had failed. There were a number of issues being raised by staff that local managers were trying to deal with and trying to resolve locally, rather than escalating them and asking them for support. And again, I think everybody, and this isn't an excuse, but everyone was under immense pressure during COVID to focus on the resources we had available getting to patients. That I think the challenge was people tried to deal with things too locally. They didn't escalate them. We didn't then respond back to the staff that raised it. It could be that they made a suggestion or raised an issue that we can't do anything about. We weren't responding back to the staff. So again, the immediate actions we've taken, we have a freedom to speak up lead. We have a non-exec director who is a freedom to speak up champion. We are increasing the number of freedom to speak up team. So we're adding 2 additional staff into the freedom to speak up. And we're also implementing local freedom to speak up champions within each of our operational areas. So we split South Central AMS into 7 operational area geographies. There'll be freedom to speak up champions in those local areas who can feed directly into the freedom to speak up guardian with any concerns they have raised. And we have got a freedom to speak up exec director who sits within our clinical team. They will deal with all of those issues and ensure that the staff do get a response back to issues that they raise. You'll notice that there are comments in the report around sexual harassment claims as well. So again, that has become as a big shock to us that staff felt like that. We were aware of some specific incidents that have been dealt with and managed appropriately, but the CQC triangulate all of their information. They've clearly picked up a theme for that. So again, we're working with our safeguarding team, the Freedom to Speak Up team, to make sure we are listening and acting on what staff are telling us. This will take a few weeks and months to resolve because we've got to build the confidence in the staff. They feel they can raise things, they will be listened to, and then they get those results.
What about the issue where staff who raised concerns are being treated badly?
So again, the CQC don't provide details with who has said what. They just give you the themes from their survey they feed back. One of the things we've had underway for the last 18 months is a retraining program for our managers. So we're moving to a just and learning culture. We're moving away from adhering to policies rigidly. So all of our managers, from our team leaders through to our executive team, are all going through the just and learning culture, which will refocus our thoughts on how we treat our staff. By reading the report, some of us were able to identify the incidents that have been referred to. So we are aware of those, and we will support those individuals if they come forward, if they don't feel they've been supported. But I think the just and learning culture is our way to transform the way we deal with our staff. So it isn't just a case, you've breached a policy, it's asking why, what was happening at the time, and then making sure the staff feel supported afterwards.
Thank you.
Thank you. I'm just going to go to Councillor Moore first, Councillor Lind, and then come back to you. Councillor Moore.
Thank you, Chair, and thank you again, Mark, for this. Not the easiest of things to do, and your honesty is very helpful. You mentioned some support from NHS England, and we've picked up as well that there's a governance review by them in progress. What's happened on that, and what are you hoping to get from that?
So as part of the downgrading by the CQC rating, we will be allocated a director, a turnaround director and a performance director that will come into SCAS and support us with our turnaround. Outside of that, our commissioners are very much holding us to account for turning the performance around and delivering on the CQC actions. So there's a monthly exec to exec meeting with NHS England. There is a senior meeting which I attend and my peers attend with NHS England every other Thursday, where we're required to present on our performance and recovery plans. We've brought in our own internal turnaround director, and this is a director who has turned around a number of organisations that failed CQC inspections. including Kent and Medway. So if he turned them around from where they were, he's come with a good credibility to come into the organisation and is making good inroads to supporting us with turning that around. So the focus from NHS England is very much on us. It's not an enjoyable place to be. It's the right place to be. But our aim is to turn things around as quickly as we possibly can, so we can then get back focusing on the thing that we do best, and that is delivering that effective patient care, whether it be on the telephone or out on the ambulances. But like I say, some of them are quick wins. We've made change already. We've got a programme for the next 10 weeks, which will lead to significant change. And then we just need to embed those changes across the organisation to make sure the staff and the patients notice the difference. The patients will notice we'll get to them quicker, we'll have the right equipment when we get to them, and the staff will notice that managers will listen and they can influence the change.
Thank you. Councillor Linden.
Thank you, Chairman. Yeah, so I've got a comment and then I'm going to ask 2 questions. I'm on the Royal Berkshire Fire Authority, and we deal with self and well visits. We were doing that during COVID on priority cases. We've also got the Thames Valley Fire Control at Fire HQ in Calcutta. And, we share quite a lot of damages, challenges, including getting people for retention, and we have some excellent people there. We've also got in this room Paul Coe, who is our Service Director for Adult Social Services. And we also deal with risk, both at the fire service, and Kathleen Borges, who's the risk manager at Strategy and Governance on this authority. And we do training on this. And I think, there are external organisations that you do need to consult and help, to assist with this turnaround and getting good practice, maybe possibly the police as well. But I can't speak on that behalf, but the chairman can. But the question, my first question is, what can West Berkshire Council do and other organisations to help and support you in trying to get good practice for the short, medium and long term, so we don't get a repetition on that? And then my second question, which I'm quite happy to repeat, about your key staffing concerns in coming months and years. What's your main barriers to recruitment, retention, and how you're addressing these challenges, including people who are going to be on the retirement schedule, the post-50s, really, as well as those post-55s who are leaving both in the public and private sectors? So if I can go to my first question first, then you can respond to the second, Mark.
So I was just writing some notes ready for your second one.
Okay.
Sorry, could you remind me what your first one was again? Sorry.
Really, how can we and other...
Oh, how West Berks could help, yes. I think it's important to note throughout the report, CQC do highlight that our staff are dedicated and are providing the best care possible. So just to reassure members, what is happening out on the road by those clinicians is where it needs to be. I'm not sure what Berkshire West Berkshire can do to support us. And it will probably link to some of the answers I give to your second question around the challenges with our staffing. Because one of those challenges is the cost of living. It's a national pay scale, and it's an expensive area to live. And we do see staff come and train with us because we are recognised as a good service to work for. But once they've done their training, they then tend to relocate back to areas where they can afford to buy property. So housing is one key issue for us. As our recovery programme develops, we'd be keen to use this forum to first of all come back and present how we have turned things around and hopefully re-illustrate the performance gains that we've made, and then using the councillors to go out and then share, with their further, with the public to the efforts that we've made. So using you as that conduit between the ambulance service and the public. And again, we need to perhaps review how we can do that further. But apart from that, I can't see anything quickly that can be done to support us from your end.
So you don't think there's any use in contacting outside organisations who...
I've written a note to contact Berkshire Fire. I mean, I live in Reading, so it's my local fire service as well. So I will certainly look at who we've got there. I mean, if you don't mind emailing me contact details, if not, I can go in. I've been with Doug Buchanan all week dealing with Operation Bridge, so I can certainly try Doug if you don't have those details.
I think that would be useful for the first step, and he can advise you further. Thank you.
Can I just jump in there? So first of all, Mark, I think we very much welcome for you to come back to see us again and perhaps report back on progress. But also, I think we'd be keen to pick up your point about also the communication and how we can help with the public and actually position, exactly what's going on and the progress made. And perhaps that's more appropriate at that time. But I think we'd welcome that as a committee and certainly as a council. So sorry, I just wanted to clarify that. Your second part of the question,
yeah, the staffing. Obviously, the staffing is a huge problem throughout the public services. We have it here, and we've got quite a lot of vacancies all over the organisation. I think it's about 100. But in all parts of our services as a council, we also recognise the cost of living with the policing and oh, sorry, Tom. And also on fire as well, and other public organisations. And obviously, Councillor Rolls is going to contact as our rep on the police crime and commissioners panel. Thank you.
I mean, the cost of living is a challenge, as you say, for all organisations, and being on a national pay scale, it makes it very difficult. Our east, so in Slough, Bracknell, the staff do get the outer London weighting, but that's as far as it extends. So we do have staff that live in Reading or Newbury and actually choose then to work in Bracknell because they can get the high cost of living allowance. We are looking at our recruitment packages. So we currently offer up to £8,000 for staff to relocate to come and join SCAS. So we're really pushing that out within our advertising at the minute, especially with new paramedics looking for employment. There is a limited number of paramedics coming out of university. Up until, I think about 4 years ago, it was a fully funded BSc course. It's now not funded. So I think it's made students look for other opportunities where they can train rather than going through the BSc paramedic course. We have just implemented over the last 18 months the apprenticeship program, which is going really, really well. And that will take somebody off the streets into an apprentice program, working in patient transport services for 9 months, where they get to know the area, they get to know how to speak to patients, they get to know the hospitals. They then move on to an emergency care assistant role, working on the 999 ambulances. And now we've even got the paramedic apprenticeship through Cumbria University, where we're training paramedics through that apprentice program. It takes longer, but we know in 3 to 5 years, we'll start to see those paramedics coming through the apprentice program as well. Whilst we have a number of vacancies, we also employ a number of private provider ambulance services. We have very strict controls over those organisations, and a patient should not notice any difference from a private provider ambulance turning up rather than a South Central ambulance, apart from the badge they wear on their shirt. They're assessed to the same level as us, they carry the same equipment, and we put around about 8,000 hours a week out through those private providers to fill the gap that we've got from our own staffing numbers. So the thing that we're trying to obviously do is stem the attrition. So looking at the reasons why staff are leaving, some of it is high cost of living. Some of it, I said earlier, is around development. So we're working with some of our primary care networks to actually look at how we can provide them paramedics rather than recruiting them directly. And we've got a number of schemes. There aren't any in Berkshire West at the minute. We've got a number of schemes across the trust where we've got paramedics that do half their time working on a frontline ambulance and half their time doing home visiting for GPs. And they're seeing that as a really good step to increase their skills and knowledge around how to assess patients in a community setting rather than an emergency care setting. The salary review is ongoing. There is a national review of all of the ambulance sector salaries, and we will wait for the outcome from that. But it's really difficult when you are competing with Northwest Ambulance, where you can buy a 3-bedroom detached house for what you can buy, you know, a 1-bedroom flat in Reading for. So it is probably our biggest issue to try and overcome that salary. But again, when you've got students coming out of university and they look at our CQC rating, we need to tell them why they want to work for SCAS. Why would they want to choose to come and work for an organisation that's rated as inadequate? Another reason why we have to turn that around as quickly as we possibly can.
Does that answer your question, Councillor Linden? Yeah.
Yes, Chairman.
Does any other members have any other questions? No, I just have one point. Oh, sorry, Councillor Moore.
It's less of a question. I just wanted to try and follow up the point about the cost of living challenge and you know, my own ignorance, if you like, as to whether in our local area, affordable housing, there's at least 2 categories of that, as I understand it, you know, would be accessible by staff of SCAS, and you know, at what sort of level, and maybe perhaps ask the officers to do a little bit of research on that and see if that just, you know, helps to nudge our planning committees, you know, and firm up the planning process in making sure that we get affordable housing, you know, properly coming through our planning system. Just a thought.
Thanks for that, Councillor Moore. I think we'll make a note of that and take that away and see what we can do, because I think it's a good point in how we can support as a council. Councillor Macrae.
Thank you. Yeah, as the issues regarding staff morale and retention, I noticed in the CQC report they say basically, I think hardly any staff appraisals are being done, and I think staff appraisals are very important. Certainly, when I was working in the private sector, if I didn't appraise my staff, my boss would be on top of me. So I'm wondering what you're doing to address that, please.
Yeah, so during COVID, we were working at REAP 4. So that's the national measure for what level of pressure each ambulance service is under. There's 4 measures, 1 to 4, 4 being you're basically on major incident standby. So our priority was to put every member of staff out on the road dealing with patient care. So managers who were clinical were out responding to patients, and every member of staff was out responding to patients. And there's a number of actions within REAP that you carry out. So you stop your training to make sure patient care comes first. You stop your appraisals. You stop meetings. And because REAP 4 went on for 9 months out of 12 last year, and we stopped all of that, that's why we've got a drop in our appraisal compliance and a drop in our training for face-to-face training for our staff. Again, one of the actions within the governance work stream, looking at our CQC recovery, is looking at what we should carry on doing when we're at REAP 4. So do you carry on doing, and I'll pick the worst case scenario, do you deliver safeguarding training to your staff, or do you have those 20 staff out responding that day to patients? And it's really difficult because we've been picked up that we're not doing enough safeguarding or not reporting safeguarding correctly. But we've also been picked up we're not getting to patients quickly enough. And it's that real balance around where you put your patients. But on the appraisal front, we have committed organisationally that appraisals will become an essential meeting. And the recovery programme is to get to 85% of our appraisals complete by the end of October and 95% complete by the end of December. And for my team within the urgent emergency care operations team, we're currently at 65%. So we've got a steep climb over the next 6 weeks to hit the 85% target. You're correct, staff value the time with their managers and they like to get the feedback, but that's the important time for them to discuss what their development opportunities are.
Thank you.
Thank you. No other questions from members? Mark, I just wanted to pick up on one angle and just make a comment, actually, which hopefully might be helpful, just in terms of how we as a Health Scrutiny Committee can support you and West Berkshire Council. One of the things that Councillor Linden and I recently did was to connect with other Health Scrutiny Committees. And I'm aware that you went to, I think you went to Wokingham in March, I believe. And actually that was one of the health scrutinies that we did meet with. So it might be just worth thinking from your perspective, if we can come together as a group of health scrutinies to perhaps even brainstorm some of these issues, because I'm aware that you are, obviously on a number of other agendas because of the nature of the report and the profile and the spotlight on that. So maybe one where you can go and think about, and do come back to me or come back to the officers if there's anything you think we can help you with as a group of health scrutinies, which might be a little bit more powerful and a bit more influential on some of these bigger issues like cost of living.
That'd be really helpful. Thank you, Chair. Yeah, we'll look at that. Thank you.
Thank you for coming along today and giving your time. Really, really appreciate it. You are more than welcome to stay for the rest of the meeting, but I'm sure you may have other more pressing things to do. But
I will leave you to it. Thank you very much. And thanks for your time.
Okay, so members, there is no recommendation associated with this report. So we're simply asked to note the report and consider if there's any further work you'd like to see on the future work programme. And I think we've sort of mentioned that perhaps we would actually like to get the ambulance service back at a later date once they've had a chance to address some of those issues. So perhaps we can make a note of that, Vicky, to consider on the work programme moving forward.
I think the idea of having a joint scrutiny with the other Berkshire West, or what was Berkshire West, would be a good scheme as well. Good idea too.
We'll pick up on that as well. Okay, so let's move on to agenda item number 6, and I'd like to welcome Bernice Blees. Is it Bernice or Ben?
It's my full name is Bernadine, but I'm normally called Ben. It makes life easier for everybody, I think.
Yeah, okay, apologies. I will refer to you as Ben if I may, because it does make it slightly easier. So Ben, welcome. You are the Divisional Director for Adult Community Health Services at Berkshire Healthcare NHS Foundation Trust. Thank you very much for attending this afternoon. And I'd like to invite you to present the report, which is on urgent and unscheduled primary care provided during the out of hours period in West Berkshire. So the floor is yours, Ben.
Okay, thank you. I'd like to share my screen if that's okay. If that'll work. And let's get my presentation.
The joys of Zoom.
Oh, I know, it's so slow. It's the arrows are moving at an unnaturally slow rate. Right, let's see if this will work. Okay, right, so if I chance going to present, is that sharing okay with you?
No, we can't see anything at the moment, or certainly I can't.
Yeah, actually my screen is black. Okay, can you see anything?
No, I don't think we're seeing anything at our end.
Okay, so let's see if I can escape from there then. So I did provide the report to you, so I don't know whether Vicky could even put that up for me then. It just seems to be having problems sharing from here.
Does that help? Can you see that okay?
Yes, yeah.
Great.
Okay, thank you. All right, so if we can go down, as I can't move this, Vicky, am I going down to the next one? Okay, so thank you for having me today, and I'm going to talk about Westcall, which is the name of the Berkshire West Out of Hours Primary Care Service. So a little bit of overview about us. We see approximately 80,000 people who are referred into Westcall per year via 111. And we're open between 6:30 in the evening until 8 in the morning during the week, and then 6:30 Friday through to 8 o'clock on Monday morning over the weekends. The people that we see then, they're all age, adults and children. they're registered with a Berkshire West GP, or they can be staying for a short period in Berkshire West, or traveling through, and we see both mental and physical health referrals. We're located then in terms of triage hubs, where we do all of our virtual triage by telephone mainly, and that's from the old Forge in Wokingham, and then also working from individual GP homes and clinician homes. We do home visits where a clinician will go out with the driver into individual residences, and we have 3 areas: one Newbury, Reading, and then Wokingham, where we do those with separate teams. And then we have primary care centres where patients who've been through a virtual triage and it's decided they need to be seen, or they may need some follow-up diagnostics, and they're based at the Royal Box in Reading and at West Berkshire Community Hospital in Newbury. Could we go down again, please? I'm avoiding saying next slide if I can.
We've got a slight problem, I think. How are we doing? Slight technical hitch our end, I think. Our turn.
It's
Doesn't seem to want to come up to the next slide, does it?
shall I just open up my own slides and just talk you through? It's just unfortunate.
We have got obviously the pack in front of us. So
Okay, that would be fine then. All right, so if I see where I am, hold on, I just have to get them open now. That's where I start to struggle with the amount of space on screen.
the next slide is entitled Westcourt Activity in Berkshire West System with a number of stats. That's page 113 in our pack, members. Oh, sorry, yes.
It's not allowing me to reduce the size so I can see the second one. I've just...
Sorry, yes, it's page 111,
Right.
access via 111. Sorry, my mistake. I was jumping forward. Does that help?
Okay, yeah, that's fine. So, so Westcall then is a key player in the Berkshire West system in that we work with, oh, sorry, before I go to that. So how we deliver the service, okay, here we go. There are different ways of delivering out of hours services. More recently, a lot has moved towards virtual triage, and that is because of the huge numbers that have been seen at the moment, but also during COVID, where we couldn't see very many patients face to face, the ability to do virtual triage was developed. However, if you just do virtual triage, then sorry, Councillor Moore, do you need...
Yeah, just be really grateful if you could define virtual triage for us.
Okay, so virtual, when we see a patient, we look into the record and we discuss with them what the issue is, and that's the triage part. If we do that over the phone or by video, then that's virtual. So it means we're not seeing them face to face. So face to face triage is where we bring them into the clinic and see them and go through everything there. Is that okay? So as a system, what we need to think about is virtual triage is an efficient way of seeing patients, but it reduces the amount that you can do with a lot of people. So if you only run virtual triage services and less face-to-face, it means you're not doing as much diagnostics. So if you need anything further to be looked at, you then need to send the patient either to A&E or to a clinic. So there are some concerns overall about which way is the best way to go in the long run. Now, we do quite a lot of face-to-face and a lot of point-of-care testing, which means that when we go to the patient's house or we see them in the clinic, we're able to do blood tests and we have the machines to test those blood tests. So we can immediately identify something like a sepsis or an issue with somebody's ketone levels and that they might be going into a diabetic problem, or inflammation blood test called CRP blood test. So we can do a lot of stuff that means we can keep that patient in their own home and deliver antibiotics and treatment straight away so they don't have to go into hospital. So we're therefore avoiding admission, pushing the numbers up in ED, but also it means that where we have quite a frail and older population in Berkshire West, it's really important that we don't just send people into hospital, because people tend to do worse if they're admitted on any kind of regular basis. So I'm going to go down to the next one. In the West Berkshire system, we're a key player in terms of admission avoidance, as I've said. Community beds, we support the local hospitals to do some of the medical clerking in the hospitals and medications, particularly out of hours and over weekends. We work in all of the care homes pretty much, delivering face-to-face visits there and supporting with flu jabs and things to support the local health economy. We cover over mental health services and work with social care, and with the ambulance service, we'll often go out and see a patient to try and avoid an admission if there's an ambulance at the house and they think we might be able to avoid them going in. What our activity looks like then in the Berkshire West system, if we look at patients seen at each of the primary care networks, the Newbury Primary Care Network has about 121,500 registered patients. So it's the third biggest in Berkshire West overall. Last year, we saw 15,420 patients via West Call, and this represents about 13% of all of the patients registered in West Berkshire, which is slightly higher than other areas, which is interesting. As a provider, West Call is around the size of an average primary GP practice. But the difference we have with a practice is the patients are known by the doctors in the practice generally, and they have some history there. When a person is referred into West Call, they will often be meeting or speaking to a doctor that they've never met before. So it's the doctor then has to go into their medical history and get an overview of the needs of that individual very, very quickly, so that they can then safely deal with the problem that they have going on at the moment. So if I go down to the next slide, to give you some idea of the different practices across Newbury, we do some analysis in terms of if there's a big increase in the number of patients coming to West Call over a year, and we highlight, and in the last year, the numbers of patients coming to West Call from Newbury area, there's been 5 practices who've had an increase of 15% or more in those patients. And then one practice, we did some analysis and discovered that 18.45% of the registered caseload had used West Call, which is almost 1 in 5 of the registered patients have accessed the West Call service. And we're trying to understand more about why so many patients from practices would be coming into out-of-hours services. You asked about waiting times and what our issues were with those. So NHS 111 referrals come to us in timed dispositions. So a disposition called DX05 means a patient who needs to be seen in less than or fewer than 2 hours. And that goes up to fewer than 6 hours, fewer than 12 hours, and fewer than 24 hours. Now, if you get a huge demand all of a sudden of lots of people needing a 2-hour service, that's how we develop waits. But we can't just develop a waiting list from that. By 8 o'clock the next morning or the next working day, we have to have seen all of those patients. And this has become quite a challenge. This year has given us a particular problem in that on August the 24th, the entire digital service that's used by NHS 111 and most of the out-of-hours providers, which is called Dastra, and that's how it's our entire patient management system. And they had a cyber attack, so the whole system closed on the 4th of August and only reopened again 2 weeks ago. So for the whole month of August and the beginning of September, we were running on paper records, and the only access we had to information was emails and then going into records of patients that we already had on our books. So it really delayed the amount of time each doctor was spending with a patient, because they were having to get a full medical history, and then we're having to do paper prescriptions, etc. So emailing them around the practices meant that everything slowed down, and was huge delays there. So patients were experiencing longer waits, and obviously we then had a lot of complaints because people were very concerned about why that was happening and worried. But also because of the digital outage, we couldn't easily message them to let them know what was happening. So it created just a whole series of knock-on effects. Other concerns that we've got is staffing is a major concern for all primary care services, particularly out of hours, because the available number of doctors isn't increasing. There was one extra doctor in the whole of Berkshire in the last year, so it's a real concern. And clinicians are less and less inclined to want to work nights and weekends. Demand levels have gone up, and that means that we need more doctors, and the more doctors we need, the more money we have to pay, because we have a lot of sessional staff who just jump on when they want to do extra hours. So then if they've already done a shift that week and they're working in a daytime practice, they're going to want more money in order to work out of hours. We've also seen an overall 16% in the amount of work we have going through the service. And the acuity and complexity of those cases has become worse as the population has aged locally, and some of it may be resulting from COVID. And we have a lot of less than 2-hour referrals because of that. And then the GP and AMP, that's Advanced Nurse Practitioner training capacity, clearly has changed with the government no longer sponsoring so many of those training places. The other thing we found in the recent year or two that has got worse is that 22% of referrals that we've seen and triaged were closed without requiring any other treatment except self-care. So that's a huge number of patients who could have just taken paracetamol or checked out the local pharmacy, but came through to the service. And it's a concern for us because it is an urgent care service. And 1 in 5 of our patients essentially doesn't really need us. To give you some idea of the conditions that we see, and I'm sorry this is 2021, but because of the outage, I can't get into some of our reporting to update the numbers. So I've given you an example from 2021. So in January 2021, the most common reason that somebody referred themselves into the 111 service and to us was that they wanted medication because they hadn't got their updated prescription from their own practice. After that, the kinds of things you tend to get is a lot of ill-defined signs and symptoms, often parents of, worried about a young child calling in to try and get help, and then things like cystitis and viral infections. In that year, we had a lot of COVID, so you'll note that the numbers highlighted on that had a lot of respiratory tract and viral infection things coming through. So some of it's reflective of COVID, but nearly always medications requested is one of the top things that we see. So there's a bit of patient education across the public that we could really do with happening. How do we break down access barriers for people? Well, because there's been an increased need for virtual triage and telephone triage, we're focusing hard on how we ensure good translation and interpretation services so that we can ensure that our changing population is able to access these services and get the level of treatment they need. West Call is also the go-to medical service for migrants housed within the West Berkshire area. So if people are housed in a hotel suddenly and aren't registered with a GP service, we will tend to go out and look after them initially. But we also find that we tend to see a lot of migrants staying in the Berkshire area generally. We also see over 100 unregistered patients every week, and many of these can be members of GRT communities and homeless. So we see a lot of people who fall out slightly outside the system, and because they can get through to us immediately by telephone via 111, it's also a fairly easily accessible service. But that also means that we're running at way above the levels of commissioning we've had. And then obviously, because non-Berkshire residents and holidaymakers can get access, we get a lot of over-the-border patients coming into our services, which is why, you know, on top of the practice patients, we get an extra 10 to 12,000 patients a year who are all non-registered or non-local. Feedback you asked about. So generally the feedback, because it's a very short time patients spend with us, it's generally about, you know, that they've been kindly treated and got what they've needed, and the staff have been professional. Generally, the complaints we get are about times, waiting times, and there are interesting ones. We get a lot of complaints about people having a triage, then been sent to a primary care centre to have follow-up diagnostics, and they get to the primary care centre, and then because more urgent patients have come in who have to be prioritised, they've maybe had to wait for an hour, so they make a complaint about waiting for an hour, which we do find a bit extraordinary because they've come to out-of-hours care rather than their local practice. And there's a complaint about an hour's wait, whereas the other option is ED, where you would wait for at least 6 to 8 hours minimum for this type of thing. So there's quite a bit of education that probably would help to have with the local population. The activity levels between 2021 and 2022 have gone up by 16%, as I've said. The majority of that is the virtual triage. People like to quickly get seen and dealt with by phone, but our primary care centres are starting to climb again after having come down during COVID. Home visits are defined really by the amount of visits doctors can get out to a house too. So it tends to be a fairly stagnant number of about 60 a day of those. So in terms of winter planning, we're working with the Urgent Care Board to develop options to redirect patients to the most appropriate outcome for their referral. Finally, we've successfully stood up the Adastra patient record management system again, and we're working through the rest of the gremlins that have inevitably come with standing up new software at the moment. So hopefully within the next 2 to 3 weeks, that should all be working properly again. We're working with system partners to try and encourage consideration around pilots. When you suddenly set up a winter service or a new walk-in centre or new access for patients to different services, what tends to happen is money floods into that, and then we lose our sessional doctors because they'll get extra daytime work from the new pilot services. So constantly, because it's a zero-sum game in terms of there is a finite number of doctors, a new service and new funding will take doctors away from an existing service, and that's a strategic piece of work that we need to be constantly doing. But we're also working with our Oxford and Buckinghamshire colleagues to try and get mutual aid going at weekends and evenings, so that if one service is really struggling with staffing, they can support other services, ensure that those patients get dealt with in a fairly quick manner. So that's pretty much it. That's my whistle-stop tour through the West Call service. If there are any questions, I'm happy to take those.
Thank you. Members, any questions? Councillor Moore.
Thank you, and thank you, Ben, for your presentation. Very informative. I'm just interested, obviously, you've had this this issue with the software system, but more you've made a comment about obviously you're working to to sort that out. When you have and indeed before it went wrong, how easy is it for you to access patient records? Anecdotally, just I think my elderly mother, went through probably this system at some point in recent months, and seemed to have to give her medical history, or relevant medical history, each time. She spoke to the next referral point, and as you commented, that does waste people's time. So just interested in all of that area.
Yeah. So that was made horrible by the Adastra outage, so that the person phoning 111 would get through to the South Central Ambulance Service team, and they would have to do the initial work through to decide where they needed to be referred on to. So they don't have access to the patient records. So they would have to ask for the history. And then when they came through to us or any of the other providers who didn't have access, they would have to ask for it again. So we did a lot of work during the outage period to make sure that we maximized our access to other patient record systems. But if the person, is only on the GP system and we haven't seen them before, that can be quite difficult to get hold of. And we also find when we tried, it doesn't enable patients to be transferred between organisations very easily. So NHS 111 couldn't easily transfer the patients and the medical record information into the email system that doctors use. So there's a big interorganisational operability problem that really highlighted itself massively in the last month. And that's something that all the organisations will be working on from now on for sure.
Does that
Thank
answer
you.
your question?
We have heard that before.
Thank you. Councillor Macro.
Thank you. First of all, I was going to ask about the Zadastra problem. A month seems a very long time to get something like this sorted out. I presume this is a system provided by a private company, and I'm wondering if you ought to be thinking of some alternative if it's taking them that long to.
Yeah, it's the longest outage ever. Sorry?
Carry on, sir.
So it's the longest outage ever in the NHS, and during the period we worked really hard to see if we could stand up another system, but some of these systems are very specialised in being able to handle live cases across very, very quickly, and others just aren't. So because all of NHS 111 and about 80%
Losing your
providers across the country use Adastra, sorry, I'm afraid I'm losing.
Yeah, it's slightly interrupted.
Okay, can you hear me now?
Yes, seems to be okay. If you want to go off camera, if that's easier as well or better, sometimes that helps. It's entirely up to you.
Yeah, I'll do that. Okay. So there was exploration of other systems during the period, but really they're not good enough at being able to transfer live patient data quickly, and they had too many restrictions. So some of the GP surgery system cannot process non-registered patients, and so that for us meant 100 patients a day. It also meant that patients not registered on the local systems, so any passing through and travelling through the area patients, didn't work on that. So they are really problematic. There's no doubt about it. And I think there's going to be a huge court case in this, and One Advanced will be sued to a pretty high level, I can imagine. But they still are the one piece of software at the moment which is able to handle the volume and speed of patient referrals that we get in the out-of-hours services. And I can't imagine that changing anytime soon because of that.
Thank you.
Thank you. Councillor Linden.
Thank you very much, Chairman. Hi, Ben.
Hi.
Two questions, really. Has the triage process worked to free up the most experienced staff to treat the most complex case? Then I've got another question. Do you want to answer that first?
Okay. Yes. So how we have our system set up is that when the flow of referrals comes in, it comes into what we call the stack, and that's essentially a huge list of all the patients in order of urgency. And we then have a piece of software that splits the stack into list A and list B. All the most urgent cases flow straight into list A to be seen by doctors, and all the less urgent or more routine cases flow into list B. And list B will have pharmacists who are trying to pick off the medication repeats, prescription ones, and then we'll have advanced nurse practitioners and paramedics who are looking at at people who, you know, have less urgent viral infections or whatever it is. So yes, we absolutely encourage our doctors to work off the urgent cases in list A all the time.
And my last question is, what can West Berkshire Council do to help West Call?
I think, you know, I don't know how we do public health messaging, but certainly coming up to winter, you know, we need to find a way to be encouraging patients to think about, you know, earaches. We get 1 million earaches, we get 1 million head colds, we get so many things that, you know, most people would have a Lemsip and go to bed early with. And it's how do you encourage, you know, somebody not to decide that their first port of call is to ring 111 because they need to be seen by a doctor because they've got a cold. So it is about, you know, what kind of public messaging. Also with prescriptions, you know, even though doctors' surgeries have notices everywhere saying, please remember to get your prescription on time, that's still our biggest referral in every single week.
Yeah, I mean, we have public health in West Berkshire, and we've got Paul Coe, who's our our service director for adult social care in this room as well. So we might be able to get some contact with. I've just had Paul nodding. But the other point raising for what you just said, Ben, is that when people get older, they tend to forget things. And do they have enough, especially if you're on multi-medication, are you running low? And then sometimes you check and you think, yes, I'm losing my medication, because people do forget when they get older. And it's the same when you're asked calls that Councillor Macros stated. No, not Councillor Macros, sorry, Councillor Moore, that, you know, that people are elderly, you're asked to repeat the same thing over and over again. I know the police do it, but they have their reasons for it. But we need to keep things simple as that sort of word onto it. And it's just something I just wish to reflect on. Thank you.
No problem.
Yeah, thank you. I'm sorry, just whilst we've got Paul Coe in the room, Paul, is that something that you're nodding at me, and just to acknowledge that we could perhaps take that away?
Yeah, I'll link in Steve Welch, our new Service Director for Communities and Wellbeing, with Ben. That's fine.
Thank you so much, Paul.
Thanks, Paul.
Hopefully that's helpful. Any other questions, members? I just have one question, Ben. You mentioned the size of the organisation in terms of being similar to a small GP practice. How many people actually work within the service? Do you know roughly?
So yeah, so well, we have in our urgent care service have about 60 to 80 people, but a lot of them work very tiny contracts. So some of them work for 8 hours once a month. So it's a very complex way of employing people. But if somebody is willing to come on and, you know, do a shift, we will take them, and that's how a lot of the services are operating these days.
Great.
But it's not a small practice. It's actually just a bigger than average is the size of it.
Okay, I think that's just helpful for the public actually to understand as well the level of resources. So, well, if there's no more questions, I'd like to thank you very much, Ben, for coming along this afternoon.
No problem. Thank you.
And do bear in mind how we can help you. If there's anything else you think we can help as a scrutiny committee or the council more widely, do get in touch, because I think that's been very helpful actually with your report. You're more than welcome to stay, but I'm sure you do have other pressing issues.
I'm in the middle of a quality meeting, so thank you very much. I'll go back to that. Thank you. Have a nice day. Bye. Bye.
So members, again, there's no recommendation associated with this report. We are simply asked to note the report and consider if there's any further scrutiny work that we want to include on our future work programme. So do let myself or Vicky know if you have any thoughts on that. Okay, so moving on to agenda item number 7, which is the Integrated Care Board update. And I see we've got Belinda Seston on the line, so thank you very much for joining this afternoon. I'd like to invite you to give a brief update on the ICB activities and commissioning plans, and also to provide an update on the formation of the ICB would be helpful. So the floor is yours, Belinda.
Thank you, Chair. So I'm Belinda Seston. It says on my introduction, my video camera, that I'm the head of transformation. I'm actually the interim place director, and I have been for the last month or so. So, right, so hopefully you have seen the report that Vicky very kindly sent out to me, for me. So you'll notice that on the 1st of July, this was D-Day for go live for the ICB within the place that we work in. It's known as Bob, the Bob ICB. Which meant that the CCG, the Berkshire West CCG of old, was disbanded. So there's been much work happening at a strategic level within the ICB in terms of starting the pre-work around developing the strategy and developing the integrated care partnership, which will be the joint committee for the ICB across health and social care. I think what's important to say that the ICB has been busy with its executive structure, putting in place the substantive roles, and you'll be really pleased to note that Sarah Webster is the incoming place director for Berkshire West, and Sarah starts on the 3rd of October. So Sarah will become your key point of contact going forward from an ICB perspective. So moving on in terms of the activities relating to the ICB, I've added in detail around the flu and the COVID vaccination autumn plan. So really just at a high level, work is underway, working with our PCNs and with an alternative provider, Oxford Health, to roll out the COVID booster and also the flu booster. And where we can, this will be co-administered wherever practical, but also where patients actually would want that. Some patients might not like to have the 2 injections at the same time. So we have to be kind of practical and mindful of that. I've added in some of the statistics just for your information around the spring booster rollout. And I think looking at the 75 pluses, you know, the England average is 78.6, and actually in West Berkshire, the take up was at 86%. So that's actually pretty good. And we can always give, you know, additional feedback on that and much more detail around those plans as well in due course. As we start to move into winter, and it was really helpful, you know, listening to Ben's presentation around Westcall and the services it provides. So there's been some additional money that's come down from NHS England that's been bid for supporting the winter resilience. So there's £1.6 million to build on the current infrastructure to support discharge in and out of hospital, and also to support the admission prevention as well. And there's about £500,000 that will support what's known as discharge to assess beds, where people who are ready to be discharged from hospital but perhaps need either a little bit of time or need to have, you know, their ongoing plans assessed further, will be able to do so in that facility. So this builds on the current infrastructure that we currently have. Apologies, Councillor Linden, did you want me to stop here? Your hand's up.
No, I'm just waiting.
He's trying to get in early with the queue.
Right, okay.
It's a tactical move, Belinda.
Oh, okay, I'll keep going. You'll be delighted to hear that there's going to be an urgent care centre being piloted in Reading. Now we're hoping that will start in early October. The specification for that service should be providing around 100 appointments a day, supporting the considerable pressures that are being felt within the emergency department. So of that 100, around 50 walk-in patients will be seen, about 25 appointments directly allocated from GPs, but also the emergency department as well will be able to offer an appointment, and we'll have access to about 25 appointments. So it's a pilot for about 18 months, and really we just need to test and see how that works. What is the access? What is the type of needs that are being seen? And again, I was really interested in Ben listening to her talk about, you know, the number of patients that actually require repeat prescriptions. So that's you know, really interesting and probably not a great use of resources. So we do need to think about that. Elective care recovery is really a national story, and we know that following on from COVID, there have been huge delays in people accessing surgery. So I think it's a good news story that we can report on. So looking at the statistics, the aim is to have no patients waiting greater than 78 weeks by the end of this calendar year, so by the end of December. Obviously they've been working through those waiting lists, so that's, you know, a good position to be in, and for them to then work forward towards, so they'll reduce those waits even greater going forward. I've added in some detail about long-term conditions, because we know with the pressure of COVID, and we know the impact that that's had, particularly on GP practices and the pressures. There's some really good pieces of work happening around blood pressure management, and actually September is Know Your Numbers month, where people are encouraged to go and have a blood pressure check, you know, to all support the well-being and reduce strokes, etc., for the future. But there's been some good work happening, and I'm just looking at the programme now. 21 practices across Berkshire West are participating in a scheme where people can monitor their blood pressure at home. And I think what's important in that the number of people participating has it's gone from 77% to 97%. That's 97% that basically know their numbers, and hopefully we'll have a plan to then manage any variation in that. So just really wanted to bring that to your attention. And then finally, I know one of the questions was around dementia. So, and I appreciate it was picked up within the Berkshire West CCG annual report, the current level of performance. So in terms of an update, the memory clinics were paused during COVID times because of the pandemic. So there's been quite a substantial program of a transformational program to actually address the waiting lists, including increase to the staff. So I'm really pleased to be able to report back that the transformation program in relating to the dementia waiting lists, that we're actually on track to meet targets by the end of the financial year. So that target is hitting 66.7%, and that's a national indicator. And obviously we can then start to get better, because obviously, you know, we want to be, we're obviously conscious that the earlier people can get the diagnosis, then actually the more planning and the better the outcomes can be. So it's obviously something we're really cognizant of. So that's a little bit of a whistle-stop tour around the ICB activities over the last couple of months. So very happy to take questions.
Thank you very much. And can I just say, it's a great report, really comprehensive.
Oh, thank you.
It's a really easy one to read and digest. So thank you for that. Councillor Linden, you're on first.
Thank you, Chairman. Yes, you'd be glad to know, this will be recorded by Vicky. I had my COVID booster, Moderna, for the first time, because I had the other Pfizer one before. A doctor, well, one of the doctors in my practice gave me my jab on Saturday.
Excellent.
And he gave me my flu jab on the other arm as well. Didn't get the stickers and all the rest of it, so I'm pretty upset about
Next
that.
time.
So I need some counselling for that, but maybe Paul can help with the service from the council. But joking aside here, I presume it's going to go on the NHS app, just in case I do travel. There's some countries are quite keen on that.
Yes, it is. It will all be linked in as before. Yeah.
Yeah, and one thing he did say was, because I had it about 2 months earlier than I planned to, but I was just called in, so I thought I'd take it and get the flu as well at the same time, which is convenient because I didn't expect to get that. I thought I had to wait a month. But he did say about another booster in 6 months' time. So I don't know if you knew about that or he got the information wrong. I don't know.
Yeah. So what I know is that we have enough supply to meet the demand. We also have built into the providers, particularly the mass vaccination sites, enough capacity to be agile and it's obviously we have to take our guidance from the JCVI if things change. So we have the supplies. We're agile enough to do as the JCVI dictates that we do.
You need to. So if you don't need it, I suspect we're getting in about a year's time.
Yeah.
Okay. The other thing was the walk-in centre, because I go in Reading, the Broad Street Mall. I'm a visitor there because of my eye checks, but it is not open for for people walking in off the street. So this Reading one is really a replacement for the walk-in centre we used to have in the Broad Street Mall, I presume.
I think it's probably slightly different. I'm not familiar with the previous urgent care centre. What I do know is they're currently reviewing the tenders. The provider will look at where the facilities need to be, and that will all be part of that tender bid. So I don't know much more than that, to be frank. So we will hear in due course where that will be located.
I mean, obviously, about a quarter of our population, or 20% in the Reading West constituency of West Berkshire Council, could use that. But obviously, we are a very rural area with a couple of towns as well. So, but that's something to reflect. Obviously, we have the Berkshire Hospital, but it can have difficulty for some people to get to. The other thing I was going to ask you about is weights. Maybe we need to declare an interest on that with one of our councillors, but certainly you mentioned about the 68-week wait, and a lot of our residents are fairly elderly, I mean, and some of them could have pain and discomfort and all the rest of it. I presume we do take that into account, because obviously people can be very vulnerable with pain, other than things like cancer weights, which are hugely important. And I presume we do prioritise those sorts of things.
Sorry, Councillor, did you mean in relation to the elective care?
Yeah, in a way, yeah.
I mean, so my understanding of acutes and how they manage their elective care waiting lists, they will be undertaking what's known as harm reviews on those people waiting longer than a certain time, and they would be undertaking them on a fairly regular basis. So, where all of those types of factors in relation to pain, deterioration, they would be taking that into account and moving people around the waiting list as they need to, based on clinical need. So I'm pretty sure that
cancer as well, obviously cancer, that
definitely, yeah. And a lot, I think, I haven't got the breakdown of the elective care recovery and where the waiting lists are. Maybe that's something to be scrutinised at another date, because that is a good point.
Okay, thank you very much.
Thank you. Councillor Macro.
Thank you. Thank you for the report. It's just very clear, as has already been said. On the first page, at the bottom, it says across Bob ICS, we will plan and provide joined up healthcare services, blah, 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 blah. And then there's a list of improvements. It doesn't seem to include improving access to primary care and dentistry, which I thought was a bit of an omission.
Very, very good question. And dentistry is probably something of a separate conversation. But no, what I was really showing is that the 4 principles set out within the report are the principles that the ICP need to support the ICS in actually achieving. And I think probably across at least 3 of those, I could see dentistry. if not the fourth as well. But yeah, so they're your guiding principles of an ICS, which the ICP will then take forward as part of developing the strategy. But yeah, no, I appreciate your point, and very happy to give an update, or the colleagues that lead dentistry could give an update on that particular area.
Also GP services, Sir Herbert.
Yeah, and again, I think they'll go across all four of those domains, to be frank. I think, you know, so the ICS will be developing its strategy, the ICP will be, you know, key to doing that. And from my understanding is the timetable for the strategy is around the beginning of December. And I think that's probably what you'd want to see, the strategy and the detail, the high level detail that sits behind that.
Thank you.
Thank you. Any other questions, members? Belinda, can I just ask you, so will Sarah be our point person in terms of inviting to help future health scrutinies once she's in place?
Absolutely, yes. So she starts on the 3rd of October.
Perfect. It's been very nice to have you along.
Not
but
at all.
equally, we will be inviting Sarah to future ones, future meetings. But can I thank you for your time this afternoon? It's been really helpful, and the report was excellent. So thank you very much indeed.
Thank you so much, and thank you for inviting me.
You're welcome to stay for the rest of the meeting. We've just got a couple more agenda items, but I appreciate you must be busy. So do feel free to drop off the call.
Thank you so much. Thank you, Chair.
Again, members, no recommendation associated with the report. We're just asked to note it. And if there's anything you want to place on the work programme, do flag that. So let's move on to agenda item number 8. And that was the Health Watch report. And I'd like to welcome Sarah Deason from the advocacy people, who I believe is here just really to take questions. So Sarah, welcome. I don't know if you can turn your camera on, but it'd be, oh, there we go. Thank you very much for coming along. Was it just to take questions, or is there anything you wanted to particularly highlight to members?
Yeah, well, just a point of clarity, the advocacy people are the host provider for Health Watch West Berkshire, so that's why I'm here at that. But Andrew Sharp is sick currently, so just really being present in the meeting and as you say, Councillor, taking any questions that I can take back to the team if anyone's got anything they'd like to raise.
Thank you, and we wish Andrew well. I'm aware he's not well, so do pass on our best wishes to him. Members, do we have any questions for Sarah and anything we want to flag with Health Watch in particular? Councillor Linden.
Hi, Sarah. Yeah, I mean, obviously you've looked at our work programme. Is there anything in particular that you think is urgent at the moment? Obviously, we've got quite a comprehensive report. We're doing dentistry again, got stammer, hospice, blood test, COVID, and GP numbers. So we're obviously going to have, obviously the chairman can comment on it, obviously, vice chairman, because obviously we've got quite a lot of active things to do before the council. Well, we've got elections in May. Is there anything else particular you'd like to raise with us as concerns? Thank you.
Not currently. I can take that question back to my colleagues. I'm not as familiar with West Berkshire as I am with Health Watch in other areas of Berkshire West. So yes, I will note that, and I will come back to you on it. Thank you.
Thank you, Sarah. I was aware that Andrew actually wanted to have a conversation about a few priority points and issues that he wanted to flag. So it might be that was already on his radar to come back to us.
Yeah.
Any other questions for Sarah? No? Sarah, I think you're off the hook a bit there.
Thank you.
Thank you so much for attending this afternoon. I really appreciate you making sure there was a presence there to connect us to Health Watch. So many thanks for coming along and free to take questions. Great, thank you. Okay, so moving on to agenda item number 10. says 10 on my work, but it's actually number 9, I think, isn't it? Yes. Agenda item number 9, which is task and finish group updates. Councillor Macro, would you like to provide us with an update on the continuing healthcare task and finish group?
There is a peer review going on, has gone on, and we thought it would be best to wait for the report from that peer review before we met, but we are still awaiting the report.
Thank you for that update, Councillor Macro, and that seems to make sense. Also, just to update you on the new developments task group membership, which was in my bucket to do. I have reached out to a number of members and I'm waiting to hear back. So I don't have any specifics to report back at the moment, but I will definitely press forward on that and make sure that we have membership, which I'll update you in between committees, I think, so that we can get that one up and running and get going on that. Any questions on that from any other members? No? Okay, so moving on to agenda item 10, work programme. So really to ask members to note the work programme and to invite if there's any other suggestions for the work programme. Does anybody have any comments or any further thoughts that we need to put through our prioritisation tool? No, not at this, sorry, no, Councillor Moore?
Not on that. I was just interested in some of the guidance that was circulated before the committee and how we might be, approaching that. But that's not quite specifically the same thing as the programme.
Yeah, it's a good point. There's quite a lot of materials that's been circulated. I don't know if members have had a chance to read those in terms of the guidance, which Vicky, I think you circulated. We probably should revisit that actually. But as you said, it's not one for the work programme in terms of substantive items. I think there were a number of things coming out of this meeting that we may actually need to look and put through the prioritisation tool. But yeah, Councillor Linden.
Yeah, maybe we can get some advice outside the meeting, because obviously we've got quite a lot of stuff to put in, and I presume everything will be out in early April because of PERDA. So maybe we can have some clarification on that, because we've got quite an extensive agenda, Chairman, and what we can and what we can't do. I presume we must probably can't even meet
from March, I believe. I think it's
the end of March, because obviously people will be campaigning as well. So
yeah, it's a good point we need to pick up on, and no doubt we'll have guidance across all committees on that. I would actually like to also flag for members of the public watching this meeting that we do, they can nominate topics through our website. There is a form to do that. So I would encourage members to encourage others as well. But just to highlight that for members of the public watching. Okay, nothing else on the work programme. Okay, well, basically just to note that that's all the business now that's been concluded of the meeting. I'd like to thank everybody for attending this afternoon. And I'd like to ask all panellists who haven't left already to remain in the virtual meeting room and not to leave until the Zoom host has confirmed that meeting is no longer live streamed.